guys, welcome back to the channel, and today we are going to see Unit 8, that is Abnormal Labor Assessment and Management. From this chapter you will get only one question, that is for 10 marks, long essay. So totally if you learn this chapter you will be perfect with 10 marks. Cephalopelvic disproportion. In this condition, if you see the pelvic which is present, the diameter of this pelvic will be smaller than the normal, either anterior posterior or transversal or oblique. In any way, the diameter of the pelvic will be smaller than the normal pelvic, which is suitable for delivery. In this condition, we do feel the baby's head is too large or the baby can't fit into the mother's pelvic. It will be very difficult for the delivery process. In this condition, we generally perform C-section, which is the safest mode of delivery in this condition. Cephalopelvic disproportion has two types. One is severe disproportion, another is borderline disproportion. If you see in this severe disproportion, the pelvic is very small. If you see the obstetric conjugative, it should be generally 12 centimeters. This is how an healthy pelvic consists. But here it is less than 7.5 centimeters. And if you see the borderline disproportion, here the diameter of all the angle is almost 1 or 2 centimeters smaller than the healthy one. If you see obstetric conjugated, it should be 12 centimeters, but here it is 9.5 to 10 centimeters. And the inlet of anterior posterior diameter is less than 10, but the inlet of anterior posterior, it should be 11 centimeter. But here in this condition it's less than 10 centimeter, and the inlet of transverse diameter is less than 12 centimeter, but the transverse is here. The transverse is generally 13 centimeters in the inlet, but here it is less than 12 centimeters. Almost 1 or 2 centimeters less in the borderline disproportion. These are the 2 degrees that is seen in cephalopelvic disproportion. Causes of CPD. In that, first, nutritional deficiency. Generally because of vitamin D we get rickets. You know what is rickets? The legs will be bow like this. So in this we have even pelvic defect also. So apart from this, there are other two conditions which occurs because of this nutritional deficiency that leads to CPD. Those are, one is rachitic pelvic and other is osteomalic pelvic. In this rachitic pelvic, if you see, the structure of the pelvic is destructive, that is it's not in the proper condition. And osteomalic pelvic, if you see here, the bone is not in the proper condition. Next, if you see, disease, injury to the pelvic bone. Diseases like arthritis, tumor or polio and injuries like fractures can lead to this condition. And next, developmental defect. Developmental defect can be like high or low asymmetric pelvic. I don't know whether you are so familiar with this word, but apart from this, polio is also in this. While developing, the defect may occur. And large baby size. In this, if you see, the baby is generally large in size. There is no problem with mother's pelvic, but still the baby is very large. It can't pass into that pelvic. So we consider this condition as CPD and we undergo C-section. Abnormal fetal position. In this, the position of the fetal is not normal and we can't conduct a normal delivery with that position. In next section, we will get to know what are malposition and malpresentation. Problem with genital tract. For example, if the mother has undergone any operation this before that is related to her pelvic region, that is what? Problem related genital tract. These are the causes that leads to CPD. Diagnosis of CPD or contracted pelvic. CPDs, the other name is contracted pelvic. Well, if you see, starting every time on the diagnosis process, we take past history. In past history, we will ask the patient whether she has undergone before delivery process or not. Either if she have been already undergone delivery process, in that delivery process, if she has any risk factor related to CPD, anything, the risk factor can be even that I have been informed that baby is very large, right? The pelvic of mother is okay, it's in the normal form, but the baby was very large, so that's a risk factor also. So like that, any kind of risk factor related to CPD has been undergone or not, we will take the history. Apart from this, any kind of accidents or any kind of injuries or any kind of disease underlying conditions like rickets, osteomalacia, polio, any kind of condition is present in the women or not. We will get to know beginning of the treatment itself. And next we will perform the assessment, that is physical assessment. We will take our measurements, height, weight, vital signs, everything. In the performing process, we will take the height. If the woman is less than 5 feet, then it indirectly indicates the women may have small pelvic. But it's not a problem for every woman. Okay, no need to worry about it. But it may be a problem, only 10%, it may be a problem in later condition. Apart from this, we will see all the joints, mainly hip joints, whether it is in symmetric conditions or not, whether the joints are okay or not, pelvic is okay or not, everything we will assess their body properly. Apart from this, we will see two conditions, dystocia and dystrophysia. Dystocia is nothing but destructure. Our structure is not in the proper condition. Dystrophia means degenerating cells. Any kind of part of our body, if there is any kind of degeneration, we will note it down also. Assessment of pelvic will be done, but generally it will be done before the labor process, but you can even perform this beyond 37th week, but generally it will be performed at the time of delivery process, that is performed by manually clinical pelvicmetry. Assessment of transversal diameter will be done. It will be performed by the fist method, that is they will place their fist in the anal region and to detect the ischial tuberosities, and by that you will get to know the transversal diameter of outlet. Apart from this, we will perform two things, that is X-ray of pelvicmetry and computer tomograph. In that you will get to know whether the patient has CPD or if she is having, at what condition do they have. Apart from this, we have one main thing, that is abdominal vaginal method. This method is very important in this condition. If you see, the women will be placed in the lithotomy position. Lithotomy position is like this, spreading her legs, the delivery position. In this lithotomy position, when the woman is made to lay down, the person one who is performing will insert their hand, right hand, inside the vagina, and the other hand will be above the ischial spine. Now the person one who is placing his above hand will try to push or downwards direction of the pelvic. If the person is able to push, then there is no disproportion. If he is not able to push, then there is moderate to severe disproportion. The management for the CPD we have based on two things, that is borderline degree or moderate degree and severe degree. For this both, if it is in the preterm, if the baby itself in 7.5 months itself a normal delivery is occurring, that is induction of labor is occurring, then we will perform the normal delivery and we will provide a preterm baby care for that baby. If it's in the full term, then we will go with trial labor first and then we will go with C-section. If trial labor is not working, then we will go with C-section. In this, do remember, in severe degree, we can't perform trial labor, that is normal delivery is not possible at all. In severe degree, we will directly go with C-section, but in moderate degree, we will try for normal delivery, trial labor. If not possible, then we will go with C-section. What are the uses of trial labor? If you see, we are reducing the C-section chances, we are reducing the pain for the mother, and if you see the disadvantage, that is quite big here. There is a chance of fetal death here, and if this trial labor fails, then the risk for the mother's life is also more. These are the management for CPD. Questions will be provided at the end of the chapter. Until then, stay tuned. Bye.